We are trying to avoid wrinkles on our face. We actually want to keep the wrinkles in our vagina. And part of how we keep the wrinkles in our vagina, called the rugae, is
Welcome to Wellness, your ultimate guide to unlocking your full human potential through biohacking. I'm your host, Ashley Daly. I'm a certified sports nutrition coach, and I have a degree in kinesiology, and I'm a former personal trainer and Pilates instructor. If you're listening on YouTube, hit subscribe, as it helps listeners just like you find this hidden health information faster. America hasn't updated its beauty laws in over 80 years, and the cosmetics industry is highly unregulated, meaning harmful chemicals are hiding in your typical drugstore and big box products. But Araza Beauty is the first paleo-certified makeup line in the US, made with real ingredients you can pronounce. No parabens, phthalates, hidden toxins like PUFAs, titanium dioxides, or silicone fillers. Their formulas are nourishing and actually good for your skin. Visit arazabeauty.com/Ashley Deely, ARAZA. That's arazabeauty.com/Ashley Deely. Today's guest is Kim Vopni, aka the Vagina Coach. I have desperately wanted to get Kim on my show for a few months now, and when she said yes, I was so excited because her work is profound. She helps women overcome incontinence, prolapse, and other pelvic floor related issues, including teaching you how to train your bladder so you don't have to go to the bathroom every hour. With a background in psychology and health and fitness, Kim blends evidence-based exercise programs with compassionate coaching to help women overcome incontinence, prolapse, pelvic pain, and other common but often stigmatized issues. She's the creator of the Buff Muff app, founder of Kegels and Cocktails, and author of several books, including Your Pelvic Floor: The Inside Story. Through her workshops, online courses, and popular podcast, Between Two Lips, Kim has inspired thousands of women to ditch the shame and reclaim confidence in their bodies. Kim, welcome to the show.
thank you. Nice to be here. Thanks so much for having me.
I wanted to take this time to let listeners know, if they can, this is definitely one that they should be watching because you have some fun things to show us. But where I wanted to start, Kim, is can you please explain what are the different parts to the vagina?
Yeah, well, I would say the majority of people, we think of the vagina as what we see externally. We see our pubic hair, our lips, the labia, and we sort of interpret that as and the whole thing being the vagina inside outside. So the vagina is actually a tube. It's a tube that attaches to the cervix. It's on the inside. So beyond, if you were to part the labia, there's an opening called the introitus, and then the tube on the inside would be the vagina. The external genitalia would be referred to as the vulva. So that's an important factor, I think, for people to know, because we kind of just generally look at the whole part of the pelvis and say vagina.
That's a really good distinction. And that's why I wanted to have you on, because I became a Pilates instructor about 10 years ago. And that was the first time I ever even learned about the pelvic floor, because I had so many clients who were leaking. Can you tell us what some of your work entails and what the pelvic floor is?
Yeah, it's important because the Pilates really, I would credit as one of the first movement modalities that started the conversation around the pelvic floor. I would say the pelvic floor within even the last year has become almost trendy. A lot more people are talking about it, whereas it was an unknown term for many, many years. And 21 years ago, when I started this work, I had no idea what the pelvic floor was, had not heard that term. I didn't know anything other than I want to prevent tearing in childbirth. That was sort of my own, that was the catalyst that got me into this work, was trying to prevent tearing from childbirth. So the pelvic floor is a group of muscles. So this is a female pelvis. Whether you have male or female anatomy, you have a pelvis. You have the bony scaffolding of the pelvis. So we have our hip bones. There's a pubic joint at the front. We have our sacrum, which is the triangular bone here at the end of that. We have our tailbone. And if this person was lying on their back, you can see the two sit bones. So the pubic joint, the tailbone, and the two sit bones are where this group of muscles called the pelvic floor attach. And there are multiple muscles. It's not just one muscle. It's multiple muscles in multiple layers. So here is again, if this person was lying on their back, so this would be the bed or table or floor, whatever they would be on, you can see the pubic joint, 2 sit bones, tailbone. So that's sort of like a triangular part. And all of this red here is all the different layers of musculature that is attaching to those 4 points. We can also see the vulva. We can see the opening of the urethra. We can see the opening of the vagina. We can see the opening of the anus as well. The layers of the pelvic floor, the first layer is primarily responsible for our sexual response. The second layer is primarily responsible for managing those 3 openings that we just highlighted. And the third layer would be primarily responsible for holding our internal organs up in place. So here's our bladder, here's our uterus, here's the tube of the vagina, that is the vagina. And then we have our rectum. So if, again, that person was lying down on their back, you can see those 3 openings, the urethra, the vagina, the anus. And this is sort of textbook how those internal organs would be nestled inside of us, supported by that sling or hammock of pelvic floor muscles below.
This is why I'm really thankful for your work, because I don't think people have seen something quite like that, the way that you explain it, which is so simple. I'm curious to learn, Kim, what weakens the pelvic floor?
The term weaken or weak is an interesting term because when people experience pelvic floor dysfunction, so let's pick incontinence right now. Incontinence is very common. Stress urinary incontinence is where we laugh, cough, sneeze, jump, and a little bit of urine would leak out. And the interpretation is if I am leaking, that must mean I am weak, and weak must mean laxity or poor tone, and it can't generate force to close off the openings or the opening of the urethra to prevent urine from coming out. So the interpretation of weakness is laxity. But weakness can also be tightness. So if we have a group of muscles that is lax, they may not be able to, might be stretched, it may be weak, it may be lacking tone. That can be a form of weakness. However, if we also have muscles that are too tight, that are rigid, that don't have blood flow and circulation, tight muscles can't react at the right time with the right amount of force to also close the openings off. So we can have laxity, we can have tightness, both can be equated to being weak.
Okay, well, then I suppose my next question is, how do we untighten some of those muscles in our pelvic floor?
Gold standard really would be to see a pelvic floor physical therapist. This is the most common thing that I say probably 50 times a day is go see a pelvic floor physical therapist. And they are really what I could consider to be the gold standard practitioner in terms of evaluating, treating, assessing the pelvic floor, and gives you a good understanding of what is the status of your pelvic floor. If you happen to be one of the people that has tightness, which when you ask most physical therapists, they will say the majority of their population actually is more tight than lax. The ways that we can address tightness can be from posture, so how we're holding our body or our skeleton, how the muscles are adapting to how we hold our skeleton, with exercise. So that could be some sort of you've seen people do foam roller on their calves or their quads. We can use modalities like that with balls or rollers or towels to help release tension in the pelvic floor. We can use our breath. So knowing that physiologically, when we take a breath in, the pelvic floor should ideally be lengthening and expanding. So we can harness that by doing more deep breath work, especially focusing and emphasizing that inhale to expand or that inhale to release. So breath work, posture, exercise, modalities like a pelvic floor physical therapist, either their hands or devices or tools, pelvic wands or something that it's like a sort of an S-shaped curved device that can be inserted into the vagina that can help find trigger points, can help release or massage scar tissue that could also be contributing to tension. Fear, anxiety, these are also things that could potentially contribute to the muscles being more tense than what we would ideally want, even down to the footwear. And this will then influence that posture that I was talking about. When we sit or stand where we have a posterior tilt, meaning the tailbone is sort of tucked underneath us as opposed to being away from the surface of the chair if we were sitting. But if we spend more time sitting or standing in a tucked position, the pelvic floor muscles, we talked about the tailbone being an attachment point and the pubic joint being an attachment point. And because our sacrum has a little bit of movement, when we are sitting with more of a posterior tilt, it closes the space between the pubic joint and the tailbone, in which the muscles then that are attaching there can adapt to being held in a shorter, tighter position. So how we hold, again, the skeleton is important, but that can start from our feet and the footwear that we have. And if we are using shoes that, even if they are called neutral running shoes, if they have a positive heel, meaning if the heel is even slightly more elevated than the front, the forefoot, that translates to shortening up the chain. We start to shorten in the calves, we shorten in the hamstrings. The hamstrings attach up into the pelvis. It can pull the pelvis into more of a posterior tilt. So many different variables in there that can influence tension.
Speaking of sitting, have you heard of the Salli saddle chair?
I know that, yes.
So it's one of my favorite things because I feel like it really changed the way that I was able to sit. It gives room for my genitalia to have plenty of room, not to be smashed into the rest of my organs. But my question was, is there an ideal way to sit?
Anything that will encourage you to, I would say, more of a neutral pelvis. Now, I caution, or I preface this by saying, when I tell you what neutral is, that doesn't mean that we have to find and stay in neutral 24/7 and that only neutral is going to be the best position that we can be in. We are designed to move and lie down and sit and stand in all sorts of different ways and different positions. From a retraining perspective, when we think about, either from a prevention point of view, so we want to maintain optimal pelvic floor function, or people who are looking to overcome certain symptoms, we want to make sure that we are harnessing where the relationship between the diaphragm and pelvic floor would be most optimal, which would be in that neutral pelvic position. So whether you are sitting or standing, we talked about the sits bones. So here's the person lying on their back. There's the sits bones and the vulva. So these are sort of the three points that we want to have in contact with whatever it is that we're sitting on. So the vulva, the two sit bones are kind of like a little bit of a tripod. You can see then if I turn this way, the tailbone is nowhere near the surface of what I'm sitting on, as opposed to here, which would be more of that posterior tilt. So this would be quote unquote neutral pelvis. The hip bones are in the same plane as the pubic joint. That would be considered more optimal. So again, doesn't mean that we can't Netflix and chill and sit on the couch and lounge around, but we don't want to spend the majority of our day here. That would allow or contribute to the muscles adapting in a non-optimal way. So nodding the pubic joint forward, coming into more neutral would be more optimal. And the other reason why that's important is coming back to our organs. I'm going to put my bladder back in here. When we are in a neutral pelvic position, we are leveraging our bony scaffolding in addition to our muscles and our ligaments and our tendons. So you can see the pubic joint acting like a bit of a shelf for the bladder. You see how it's kind of nestling there, and then the uterus would be resting on top there as well. If I was to, again, spend more time here, I'm now losing the scaffolding support, and there would be more strain on the muscles, the ligament, like all the other structures. And part of their job is support, but we want to leverage all of the support mechanisms that we have.
You're making this sound like it makes so much sense, but I feel like people could still be a bit confused about it because you just showed me the way that the bladder sits in the way that the bladder sits in our bodies. And I'm curious to learn, just from maybe my own personal experience, I feel like I have to go to the bathroom all the time. I go to the bathroom about every hour, but because of you, I've been trying to hold it for 2 hours. So can you walk me through bladder training and what our bladders should be able to do?
So normal voiding from a urination perspective, if you're drinking consistently throughout the day, if you're not dehydrated, you don't have any bladder irritants, general normal voiding would be every 2.5 to 4 hours. If you're going more frequently, then we want to say, why? Did I have a huge volume of liquid? In which case you're going to need to void more. There's a bigger volume of liquid. Did you consume bladder irritants, spicy foods, acidic foods, artificial sweeteners, alcohol, caffeine, dairy for many people, sugar for many, carbonated beverages? Those are all common bladder irritants. So if you consume them, not to say that everybody will be irritated by every single one of those things, but if you are going frequently, I would have you do a bladder diary and track how much water are you drinking? How much are you pooping every day? And do you poop well? And what sort of foods or beverages are you consuming that could potentially be irritating to your bladder? So that's one thing. And then now the posture that I just highlighted, here's our neutral pelvic position. But if you look inside here, can you see the muscles are right here? Okay. If we have tension in those muscles, let me put my bladder back in. They're nestling right underneath the bladder. So if we have tension there, that is going to irritate the bladder as well and make you feel like you need to go more often. And if we have anxiety, if we feel cold, if we're tense, stressed, that can also contribute to more tension that can then heighten that responsive feeling like you need to pee. Many people who feel like they need to go all the time, or they may leak, or they're afraid of not having a bathroom, they might restrict their fluid. Well, if I don't drink water, then I won't have to pee. So then we become dehydrated. Concentrated urine is dehydrated urine. That's going to irritate the bladder more often. So that's going to make you feel like you need to go more frequently. So we have bladder irritants that could do that. Tight muscles can do that. Dehydration can do that. Constipation can do that. So here again are the organs as they would be nestled inside. And here's our rectum. If we, this isn't a huge space within our pelvis. So if we have a rectum that is full, that we haven't emptied properly, it's going to apply pressure within the pelvis and limit the space of expansion for the bladder. So you will feel like you need to go more often or more frequently. If you have low estrogen, this could be postpartum, it could be nearing and post-menopause. When we're in a low estrogen state, estrogen plays a role in the tissue integrity, the suppleness, the juiciness of the tissues. And when we lose our estrogen, or when we're low in estrogen, it will also heighten urgency, frequency. It may contribute to dryness in the tissues that is going to exacerbate symptoms. Estrogen plays a role in helping maintain the pH of the vagina, but also sort of the robustness of the muscles and their capacity to do their jobs as well. So that's another thing that could potentially contribute to those sensations of urgency or going more often than 2.5 to 4 hours.
You are speaking my language. I love talking about estrogen and bioidentical hormone replacement therapy. In fact, doing research for this episode today, I listened to your episode with Kelly Casperson. How many seconds should we be voiding to make sure that we're using our bladders correctly?
It's about 1.5 cups of liquid. The amount of time on average, this isn't an exact science, but the amount of time generally to empty 1.5 cups is somewhere between 10-ish, 12, 15 seconds. And ideally it is a steady stream. So if you're sitting down, if you have a hard time starting the flow of urine, if you notice that it's strong and then it slows down or stops and then it sort of starts again and you're kind of in a bit of a fit, like start-stop situation, that's not ideal. We ideally want to sit down within like a second-ish, starts to flow, strong, steady stream, and slow, then stops over 10 to 15-ish seconds.
That's what I've been working and training on. Now, in the beginning of this episode, you mentioned you helped women who said they didn't want to tear in childbirth. What can women do, whether they're first-time moms or they're having their third, fourth, fifth round? What can they do to make sure they don't tear in childbirth?
Tearing is incredibly common. Well over 50% of people will have some degree of tearing. So it would be considered, I don't want to say normal, it's common. But there's nothing we can do to 100% prevent tearing, but there are things that we can do to lessen the likelihood. Seeing a pelvic floor physical therapist during your pregnancy, working on the balance of that tone. So making sure we aren't too rigid and stuck, that we have good balanced resting tone within the muscles good blood flow, good circulation, the pelvic floor can react at the right time, move through a range of motion, and can also release tension will be important. Practicing certain birth positions. So if we look at the most common or most favorable birth positions, such as I don't like squatting so much for a second, like a pushing phase of labor, but an early stage labor, I do like a squat position, a staggered stance position, an all fours, a side lying position, a tall kneel position. So those are more favorable birth positions, I would say. So we can incorporate those and make those exercises while we are pregnant and learn how to, and we can do this with the assistance of a pelvic floor physical therapist as well, learn how to control our pelvic floor there as well. So can we relax the pelvic floor in those positions? Can we activate and lift in those positions? And that helps give us knowledge of what positions is my pelvic floor responding most appropriately, which can maybe encourage me to pursue those positions, at least initially, while I'm in the push phase of my birth. Perineal massage is something we can do on our own. We can have a partner who can do it. It's a little bit more challenging to do on our own. So having somebody who can do it for us is beneficial. The product that I used is called the Epino, EPI-NO. This is a biofeedback device that is a silicone balloon that's inserted into the vagina, inflated a little bit, and you feel the sensations of stretch and a bit of pressure, discomfort. So it's trying to mimic the sensations that you will feel when you're birthing, obviously to a much lesser degree, but birth is not comfortable. Birth is uncomfortable. And so when we experience discomfort, we usually are, you're guarded, right? And so we need to learn to experience those sensations and learn how to soften and learn how to yield. So the Epino is one. I will say it's not available in North America. So you would need to know somebody in Australia or Europe who could purchase for you and get it to you. It was available in North America at one time, but Health Canada and FDA put in new regulations. And anyway, it's no longer here. It's a great device. And it's very frustrating that it's not here. I was the Canadian distributor for 14 years. I absolutely love the product, but you can do manual perineal massage as well. So those are a few ways that I would say. It's connecting with your body, connecting with your breath. It is also calming your nervous system. It is building trust in your body. It is almost connecting with your babe. Like, we're a team here. We're going to do this together, and having this self-talk with this baby inside of you, with your body, and educating yourself ahead of time. So you go into birth with this confidence. A lot of us just go in, we show up, we're like, I don't know what's going to happen. And I see there's a lot of screaming that happens and pain. And so we have interpretations or beliefs about birth. And I think if we watch really powerful birth stories, Ina May Gaskin has beautiful examples of this. It shows us how it can be done different from what we see in the media.
Oh, that's a really nice way to put it. More refreshing than what you see on TV. If you have a tear, can you recover from it with those same methodologies that you just mentioned, or is there something else that we should be doing?
So first and second degree tears, I would say they're more superficial. They would be easier to heal from. Some may not even require any stitches. If you have a third or a fourth degree tear, these are more, they contribute to more complications. I think every single person giving birth should be referred to a pelvic floor physical therapist. That should just be a normal course of action. It should happen, be standard of care. It's not. There is a movement happening now that people who have third and fourth degree tears, it is becoming more common for them to be referred on because of the known increased risks of incontinence, organ prolapse, and especially anal incontinence as well. So it's called OASIS, which is obstetric anal sphincter injury. So third and fourth degree tears will be influencing the sphincter, which is going to lead to more challenges down the road. So we can heal from those tears. The degree of the tearing can influence like how long it would take to heal and what sort of long-term ramifications there may be. However, the sooner we can address that with increasing blood flow, circulation, strengthening the muscles, releasing tension in the muscles, seeing our pelvic floor physical therapist. I generally say around 6 to 8 weeks postpartum, but we can see them earlier. The internal evaluation component may not happen right away, depending on the state of the person's healing. So I use red light therapy, heat, herbs in the bath, so sitz baths, and again, encouraging that blood flow and circulation. And within the first few days, regardless of whether you've had tearing or not, I encourage quite a bit of rest. But you're not really upright against gravity. Let the tissues have some time without gravity. Skin to skin with babe. People are coming to you. You should be the one who is also being nurtured. We don't have this. Our culture in North America is very focused on babe and supermom mentality. Other cultures around the world are really there to support mom. And not that babe is an afterthought, but there's somebody looking after babe, but there's a lot of people looking after mom, because when mom is doing well and when she is replenishing her energy, and she can then make sure the babe has got what it needs, right? So I think we need a little bit more of that in terms of a healing mentality in North America.
I like that attitude. I very much agree. I wanted to go back and touch on the herbs. What kind of herbs will you take in a bath?
So there's different blends. There's a few different companies. Witch hazel is a very common one. Calendula, chamomile. It could be dependent on the company that you work with, but Earth Mama. Oh my gosh, I'm forgetting the name now. It's been so long since I've used it. Earth Mama Baby something. Sorry, I'm forgetting the name, but they have a great product. They usually come in little, almost like a little tea bag. So you can buy loose herbs and make a huge batch of tea and pour it into bath water. So this is what my mom was doing for me daily, would be making these big batches of herbs. The store, I'm in Vancouver, Canada. There was a store called Gaia Garden, and they had a perennial herb blend. You can find a lot, like if you go to birth and postpartum supplies online, you can find a lot of postpartum healing herbs. Again, the ones that I've listed are quite common in those blends, but they may have lavender, or they may, like, there's lots of different nuance in there, all surrounding reducing inflammation, providing healing as a bit of an astringent to help sort of tighten's not the right word, but sort of. And yeah, so that I don't even remember what was in my my blend particularly. I do know witch hazel was in there. I do know lavender and calendula were in there. But there's many different kinds.
Walk me through what kind of red light you're using. So I have a Joy Lux, but I'm not sure if people are wanting to use that maybe right after childbirth.
So I also have a Joy Lux. I was their first Canadian distributor, and they are really who introduced me to red light. This is probably 12 or so years ago now. I'd never heard of red light therapy. I was a little bit skeptical, and I'm thinking, I really appreciate research. I'm not stuck on, I don't only rely on research, but I do like to have a little bit of research, especially if it's something new. So they were amazing. I love the product. However, postpartum, the thought of something going inside after you've had, especially a vaginal childbirth, is a little bit just not something you want to do. Some people would, if it was a thinner device, potentially you could. I know that Joy Lux has come out with some postpartum support as well. However, post-op or postpartum, I prefer something external initially. So the way that I was using it was, I didn't have red light therapy when I was postpartum myself. This is what I used post-operatively. I had a rectocele repair about 4.5 years ago. So had I known about red light therapy in my post-op, I would have absolutely used it the same way. I was lying on my back. I had a red light panel. So you can get red light devices in all sorts of shapes and sizes now. At the time I purchased mine, most of them were a big rectangular box. Now they're ones that are in bendy fabric. There's all sorts of cool ways you can do it. But I was lying down. I would shine the red light onto my vulva externally. So it was positioned. If I was lying on my back with my knees bent, it was in between my calves and my bum, shining directly on my vulva. And I would lie there for a period of about 20 minutes. I would lie down also on a heating pad, so I would stay warm in my body, because tension can restrict, again, blood flow, circulation, and healing. So we don't want to get in a state of rigidity. We want to stay nice and warm and soft. But that's how I used mine.
Tell me about Kegels.
Dr. Arnold Kegel, I want to honor the fact that he saw his patients experiencing challenges. Generally, it was a postpartum population. with pelvic floor dysfunction, and they were having difficulty contracting, relaxing their muscles. He used a biofeedback device called the perineometer that helped them see. And so they could connect with what it felt like and what did they need to do to contract and to relax. So that's where the Kegel exercise came from. It's a voluntary contract and release of the pelvic floor. The interpretation of Kegels over the years is that it is a squeeze, and that if we squeeze harder, it's going to get tighter, and tighter is better. There's also a lift component. So part of the function of the pelvic floor is not just squeezing to close the openings, but lifting. So there's a group of muscles in the pelvic floor called the levator ani. That literally means lift the anus. Part of that organ support is a lift. And that sort of has been left out or not fully understood when we think of just a Kegel. We have evidence to show that Kegels, which is a voluntary contraction and lift and let go of the pelvic floor muscles, work when they are done correctly, when they are done consistently. We also have evidence to show that the majority of women do them incorrectly because we have never been taught. We've been maybe told, we have heard about Kegels. We might have been given a pamphlet. It's the muscles you use to stop the flow of urine. But how people do that is, unless we've had somebody evaluate our technique, we often are doing that incorrectly. A lot of people will squeeze their glutes or squeeze their inner thighs. Some people will bear down, hold their breath, thinking they're doing a Kegel when actually they're not. So Kegels can be an absolutely amazing tool and are proven in research. And gold standard in research would say do 3 sets of 10-second holds 3 times a day. Now, I don't know about you, but I am not taking 3 separate times in a day to stop and drop and do my Kegels, which usually they say lying down in your bed or sitting at a red light or brushing your teeth. So where I want to expand on the Kegel conversation and really what formulated my philosophy with pelvic floor health and fitness is we need to train the pelvic floor in a variety of positions with the breath. So knowing that the breath has an influence on the pelvic floor, we need to bring that into the training that we do. But also, if I was forever just squeezing and releasing my pelvic floor at a red light, or while I brushed my teeth, or lying down in bed, that from a fitness principle, if I want to train for a marathon, I'm not going to sit down and move my feet as if I'm running. I'm going to be upright and I'm going to be running, and I'm going to be running at different speeds and different distances and different terrains so that I'm preparing for the race. With Kegels, I need to train for when I need my pelvic floor to react, when I lift weights, when I sneeze, when I lift my baby, when I'm pushing a heavy door open. That's when we need the pelvic floor to be at its best, but it's also when we notice when it's not at its best, because that's often when symptoms show up. So if we are only training it in a seated position or lying down, that's not going to translate into being really robust in its ability to help us standing up or moving at the gym or running or, all the things that we need to do. So Kegels 2.0, 3.0, whatever you want to say, is combining pelvic floor muscle activation with the breath and whole body movement. And we now thankfully have some research that's starting to catch up and basically confirm my bias that Kegels as part of a resistance training or done prior to a resistance training program is more effective.
So when I was getting certified to become a Pilates instructor, I remember my teacher telling us, if you want to do them correctly, imagine you're trying to suck up something like liquid through a straw, through your vagina. And I feel like when you think of that visual, you're like, oh, I guess I do feel that upwards motion, like you said, rather than bearing down.
So just to reflect on the sipping. So there's a few cues that kind of rank the highest. I have a whole slew of cues, and there's no best cue. It's the one that's best for you. But generally speaking, most people identify with picking up blueberries with your vagina and your anus and putting them back down, or sipping a smoothie through a straw with your vagina and putting it back down. Those rank up pretty high in terms of the ones that people connect with. Research said squeeze your anus. Squeeze and lift your anus was the one that showed to be the best in research. But again, it's really dependent on the person and their execution of their interpretation of the cue, but then the execution of the exercise. So in terms of, to answer the question of what else can we be doing to strengthen the pelvic floor, a lot of people think strong means tight, and a tight vagina is what we want. And we want an element of tone. We need an element of strength, endurance, tone, and support in those muscles. But in order to have the best capacity to generate force, we need the muscles to be able to be at their optimal resting length. So releasing tension is one of the first things we need to do in order to be able to generate strength. And so that again is the posture piece, the using exercises to help release tension. There's one, I have the posterior pelvic floor release where you're sitting on a tennis ball or a yoga tune-up ball, and it's in between your sit bone and your anus, and I always say the ball is like a strawberry and your muscles are like chocolate, and we want the chocolate to melt over the strawberry. So that's a good way to help release tension in the pelvic floor. That then increases blood flow, increases circulation, but puts the muscle at its optimal resting length so that it can now go through the full range of motion when we think about picking up blueberries or sipping a smoothie through a straw. And then, of course, we need to put the blueberries back down. So when we are educating our brain and the muscle about that full range of motion, we are better able to, throughout the day, not be in a stuck, tight position, if that makes sense. So releasing tension is a way to start. Then we have, I call the core breath. So that's combining basically doing a Kegel, but thinking about incorporating the breath and those cues. Then we want to layer it into movement, like bridges, like squats, like bicep curls, like push-ups. So very functional movement patterns. We want to combine that in. And ideally in a optimally functioning pelvic floor, we shouldn't have to think about blueberries and sipping smoothies. The pelvic floor should pre-contract without us making it do that. It pre-contracts like milliseconds before we cough, sneeze, pick something up. And when we lose that ability for whatever reason, childbirth, scarring, surgeries, falls, tension in the muscles, we need to retrain that. So when we're using the breath, we exhale, pick up the blueberries before we exert the force. So before we push up into a bridge, before we stand up in a squat. So that's kind of the retraining process. Then we start to add load resistance, just like we would in a Pilates class or a resistance training program. We start to add progressively harder load, whether that's more sets, more reps, more weight, increase the speed or the power, like the speed at which we're executing that so that we can train for power. So there's all those sorts of ways as well. Then I'm going to move on to devices, because that's a natural question afterwards. Like, what about this device that I saw? What about this chair that I saw? What about these? And we have all sorts of technologies and devices that are marketed to us, which I will say there are some that could play a beneficial role. They are in varying degrees of cost, some being very, very expensive, some being not as expensive. However, I always say if you have money to invest in a device, I would take your money first and invest in a pelvic floor physical therapist so you understand the status of your pelvic floor before you use a device that could potentially exacerbate a situation. So if somebody already has tension and they now sit on a chair that does 11 to 13,000 Kegels for you, you may generate more tension. Or if I'm squeezing an egg or a ball and I'm holding it in more, that could again be generating more tension. So it's important to understand the status of your pelvic floor first and have your PT help you understand if one of these devices would be beneficial. Because I think there's a lot of really cool technology, and for certain populations, they could be great. But I also always say that if you are able-bodied, if you can move those muscles, if you don't have nerve damage, you don't have spinal cord injury, you aren't challenged in terms of your mobility, we should be doing the work, not a machine. We shouldn't be outsourcing it. We should be doing the work.
It's kind of like when you start an exercise program, you can get in there and start pushing all this weight around, but if you're not in the right form, you might actually injure yourself.
Yeah. And that's an important point too. I'd like to highlight is if you pay attention right now, I'm post-menopause myself. So a lot of who I am listening to and following is in the menopause space, and menopause is having a moment, and it is a well-deserved moment where there is a lot of people talking about perimenopause and menopause and the challenges of this phase of life and what we can expect and how we can manage it and what have you. So heart disease, diabetes, bone health, brain health, these are all other aspects away from pelvic health that actually the menopause movement is helping highlight pelvic health as well because of genitourinary syndrome and menopause. But my point being, we are hearing messages that we need to lift heavy weights and that we need to do impact for our bones, for our brains, for our heart to offset age-related muscle loss. And I 1000% agree with that. However, if we don't have a pelvic floor that is in a position to manage those loads and that impact, then we could be exacerbating already existing conditions like organ prolapse or incontinence, or they may show up for the first time. And then people are thinking, oh my gosh, what's happening to me? Heavy lifting is bad or jumping is bad. So we need to establish and maintain a strong foundation so that we can do all of those things. And even if we don't have a strong foundation now, before we go and try to lift heavy or jump, let's establish that foundation first so that we can then get there.
That's so important, Kim. So now, speaking of exercise, can you give us 2 beginner and 2 advanced exercises to help strengthen our pelvic floor?
There was a urogynecologist that I worked with earlier on in my career who I met on Twitter, Dr. Bruce Crawford, who is the creator of a program called VieLight, which is pelvic floor Pilates. And he was a surgeon. He's a urogynecologist. And he said, I'm a good surgeon and I perform a good procedure. Why is this person now back on my table? So he said, there's something that we're missing here. And he uses the term pelvic floor dysfunction, like incontinence and organ prolapse, is a fitness issue. And so he then said, all right, let's look at fitness. And he looked at Pilates movements, yoga movements, resistance training, and he looked at about 150 different movements. And he used wireless EMG. So these were little electrodes placed on the abdomen, the inner thighs, the glutes, and the perineum. Now, not uber super precise, but enough to see some activation within these specific muscle groups. And he wanted to see what movements of this 150 were recruiting the pelvic floor the most, and at what point in that movement was the pelvic floor most engaged. So he narrowed this down to a group of 10 exercises. I'm going to highlight a couple that I have, even if I had not done that program, I would still always recommend that somebody do, and then how to make those harder. So 2 very fundamental exercises would be a squat and a lunge. We could start beginner wise. I'd probably have somebody do a pelvic tilt or a bridge, which was on his list of top 10, as were the squat and the lunge. So let's start with the bridge. In a bridge exercise, somebody is lying down on their back, their knees are bent, their feet are flat on the floor, their shins are vertical, so the heels are fairly close in towards their bum. Gentle curve in their low back, so kind of that neutral pelvic position again. And to bring the pelvic floor into that movement, we want to first connect with that inhale to expand the pelvic floor, exhale, pick up the blueberries, and then we would lift our bum off the ground, pushing our hips up towards the ceiling or to the sky. And then we would inhale and release the pelvic floor as we are coming back down. We've all probably done a bridge in Pilates or yoga, or we've maybe seen people do hip thrusts. That's a bit more advanced version of a bridge. But we want to bring in that core breath. We want to bring in that voluntary pelvic floor activation, lift, and then let go as we bring it in, as we coordinate it into that movement. And this, I'm making it sound like it's no big deal. It's easy. To learn the core breath is the hardest part. Most people come into the program and they're like, oh my God, I can't even do the breath properly. And they spend a couple weeks trying to get the breath nailed down.
Yes, I thought the reformer was going to be hard to learn. It was the breath work.
Yes. So we have to nail that part first. And people are like, can't I just do it the way that I did before? No, we're harnessing the normal physiological response of the pelvic floor with the diaphragm. So it is important. So we do the core breath. We layer it into a bridge as an intro movement, or even a pelvic tilt where we're on our back, same position with our feet. And instead of lifting the hips off the ground, we just simply tuck. We pull the pubic joint towards the belly button and we flatten our back out. And then we unroll and get the curve back in the low back for a pelvic tilt. So those would be, I would say, introductory. Put the core breath with that. Those are really, really good ways to strengthen your glutes, to mobilize your spine, and also to strengthen your pelvic floor. Coming up against gravity is going to be naturally just a little bit harder. And I'm going to pick the squat. The squat is an exercise that we have to do. We have to do this exercise in order so that we can get off, in and out of chairs, on and off the toilet, in and out of cars as we age. That's really, really important. And watching my parents age and now being surrounded by other people in a senior's home, we have to keep moving. We have to keep standing up and sitting down unassisted for as long as we possibly can, so that we can do it for as long as we possibly can. So squats are one of those exercises. Squats are also on that list of Dr. Bruce Crawford's top 10. So when I first learned from him, his breath in his program teaching the squat was to exhale on the way down and inhale on the way up, which was opposite to the normal reaction of the pelvic floor. So I questioned him on it. I went down to his lab in Reno, Nevada. I hooked he hooked me up to his wireless EMGs, and we were just playing around. Like, does breath really make a difference? Now, this was N of 1. This was just me. But when I did it the way that he taught the breath versus using the core breath, I had better pelvic floor activation when I used the core breath. Whether we could translate that into a big, RCT trial, who knows? But generally speaking, I would teach it the opposite to what and I've told him this, and he knows, and he talks about it in his course now as to what I do. But inhale. So as you're coming down into a squat, you're standing, you're going to hinge at the hips, stick your bum back, bend your knees, almost like you're sitting into a chair. So you're going to inhale, expand and lengthen the pelvic floor as you're lowering down. And then you're going to exhale, pick up your blueberries, and then you stand back up. So that would be more of a beginner squat. To make that more advanced, we talked about the need for changing other variables like sets or reps or speed. So we could add weights for a little bit of extra resistance. We could increase the number of sets or reps that we do. We could also do a jump squat. So we would lower down, and then we were going to exhale and explode off the ground. And then as you get more trained, as your pelvic floor becomes more automated, your breath is going to change slightly, and you may not always be quite as intentional with pick up your blueberry right now and let it go. We get back to a point of being a little bit more automated, because we should get to the point where we can allow the pelvic floor to react just as it was supposed to on its own anyway. That was a long answer, but
but I appreciate it. And this is why I wanted to have you on. I know you're so passionate about teaching this. Are we doing damage if we are bearing down on our pelvic floor, trying to urinate as fast as we can, or potentially pass gas that feels a little tough to pass?
On occasion, if you're trying to get a nice big juicy fart out and you bear down a little bit, don't panic, you're fine. But if you were doing that every single day, if you were sitting down every single time you were peeing and you were trying to get it out as fast as you can, if you were straining every day because you're constipated, yes, over time, that is damaging to the pelvic floor. So we want to make sure that we are pooping well. We do all the things. We eat properly, we move, we drink water, we use a squatty potty, we release tension in our pelvic floor so that we have an effortless bowel movement. We also, when we sit down, we should not push our pee out. If we have to push, is it because our muscles are too tight that they're not relaxing, that allows the bladder to contract and empty? Or do we have some sort of prolapse that's in the way that's hindering? Is it because we just want to get out of there as fast as possible and we want to power pee? We're interrupting the normal messaging of the pelvic floor relaxing so the bladder can contract, or so the rectum can contract and empty. Once in a blue moon, no, it's not. Don't panic about it, but it shouldn't be your normal practice.
Okay. Thank you. I appreciate that. I heard you say on your podcast that there are now over 80 million women over the age of 40 living in America. How can we take care of our vaginas as we age?
Yes, it's a huge number of people that are reaching menopause every year. And we think of it, half the population being women. And yeah, the stat that you shared there, it's a huge number of people. And most people are sidelined, as I was when I reached perimenopause, never having heard the term perimenopause. Now, that's 10, 15 years ago almost for me. And I know a lot more now, but I needed to figure that out on my own. It wasn't being blasted on social media at the time. So thankfully it is now. And I feel like the next generation is going to be much more prepared and not as sidelined as we were. But if I was to say what I would recommend for people within the perimenopause phase of life, so perimenopause generally being 6 to 10 years prior to the onset of menopause, The average age of menopause is 51. Not to say that everybody's going to be, I actually was literally 51, but it could be 43, 45, 48, 54, average age 51. And the 6 to 10 years prior to that one day of menopause is your perimenopause. So we start to have hormonal fluctuations. We may have changes. We do have changes to our overall hormonal milieu that can also influence our thyroid. Our thyroid can also influence our digestion and potentially constipation. So we kind of have a chicken and the egg. We don't know which one necessarily has come first, but we just know that things are becoming a little bit different, maybe not as optimal. We may not be sleeping as well. We may not be recovering from exercise as well. We may start to have painful sex. We might experience leaking, or leakings may be getting worse, or we have symptoms associated with pelvic floor dysfunction either for the first time or they're starting to get worse. So in terms of what I would recommend working with a practitioner who is knowledgeable in perimenopause and menopause, who understands testing for hormone therapy and thyroid. Get tested get tested as a baseline in your early 30s even, so that you know when you feel good, and then every few years you can check from there, or if something starts to shift. Being ahead of that can help prevent the likelihood of it now influencing urination or constipation or sexual activity or energy levels. See a pelvic floor physical therapist once a year, even if you have no symptoms. Just like we go to the dentist once or twice a year, we brush, we floss, we see the dentist, we go to the dentist, even if we don't have a toothache or a bleeding gums or any issue, we just go because, I'm supposed to go for my checkup. And if we took that same practice into pelvic health, I really think the world would change. It would end so much suffering that women think they accept as normal. So see a pelvic floor physical therapist once a year. Moisturize your vagina. So I talked about hyaluronic acid being something that we produce in our bodies. We produce less as we age. If we can apply similar principles, like we spend lots on lotions and potions for our face, and we are trying to avoid wrinkles on our face, we actually want to keep the wrinkles in our vagina. And part of how we keep the wrinkles in our vagina, called the rugae, is with moisture. And that can be a vulvovaginal moisturizer with hyaluronic acid. At some point, we may add vaginal estrogen. I generally say around the start of your menopause, sooner if you have symptoms. So if you're starting to experience dryness, itchiness, burning, discomfort, like sandpapery type sex, add in your estrogen there as well, and also a good lubricant during sexual activity. So estrogen, lubricant, moisturizer, they are like a team. One doesn't replace the other. They all work for different situations, but those are all good for your overall vulvovaginal health. Drinking enough water. So staying hydrated, 2 to 3 liters of water, eating a diverse variety of foods so that you have good gut health and you're pooping really well. And also ensuring you have adequate protein and amino acids, because just like the rest of our body, if we want to build muscle, we need to consume the building blocks that our body will use after we have done that exercise. And pelvic floor muscle training, and especially progressive loading in our pelvic floor, is no different. So we benefit from protein, we benefit from creatine, we benefit from collagen, just like the rest of our body does. The pelvic floor muscles are just like the muscles in the rest of our body, and what we consume and how we move them will play an important role in terms of their ability to offset age-related muscle loss and keep functioning as we need to. And then all the other things I said, pay attention to your posture, have some sort of a movement practice throughout the day, and don't sit in a tucked position for extended periods of time.
You answered so many questions subsequently in that answer, so I really appreciate it. One of the words that you touched on was suffering, and we talked about tearing, painful sex, incontinence. What else do women come to see you for that they're suffering from?
So I don't want to say that there's no suffering with leaking, but leaking and urgency are, let's say leaking. So stress urinary incontinence is something that women sort of put up with. They can put a pad on and they can carry on. Again, I don't want to say that nobody suffers with that. It will eventually worsen. And I would say suffering becomes more prevalent when they are now planning their lives around the bathroom, or it's interfering with their sexual activity. Urgency is another one that I think people do suffer with even from the beginning, because they all of a sudden they have this overwhelming urge and they need to run to a bathroom, and then they start being afraid to socialize, being afraid to exercise, being afraid to do anything because they're not sure when that urgency is going to hit. The one that I see the most suffering with is pelvic organ prolapse and pelvic pain. So pelvic organ prolapse is where the bladder, the uterus, the rectum, sometimes the intestines can start to shift out of their proper anatomical position, and they can bulge into or descend into the vagina. And early stage prolapse is often asymptomatic. 50% of women who have given birth have some degree of prolapse, but most don't know it, again, because we don't know about it. We don't hear about it. Nobody screens for it. And so it's not often until it's usually a little bit more advanced when people find out they have a prolapse. And then they feel angry, resentful, afraid. They're afraid to move. They're thinking, why didn't anybody tell me about this before? I could have maybe prevented it. And the fear they have of movement, the shame they feel with intimate relationships, the way that they start to avoid social interaction, especially if they haven't had a good bowel movement that day, or if they're not sure if there's going to be a bathroom nearby. They may withdraw from intimate relationships because they don't want their partner to see or feel it. They may feel discomfort with certain sexual activity. So that one I has, in my opinion, and with what people have shared in my community, that one seems to have a greater degree of quote unquote suffering, as does certain types of pelvic pain, especially chronic pelvic pain conditions. There's so many different versions of pain. And again, those are pain. Chronic pain is exhausting. It consumes your thought, as can other types of pelvic floor dysfunction, but can consume your everything. You aren't as present at work. You aren't as present with kids. You aren't as present with friends, loved ones, activities. And so it really becomes a huge distraction and interferes and affects in a negative way people's quality of life. So in my experience, that's what most people come. I'm working with people with incontinence, pelvic organ prolapse, and pelvic pain.
I'm so glad that you shared that, because your work is so important. I love that you're making the word vagina not taboo anymore. Now, you've mentioned pelvic floor physical therapist a handful of times during this interview. Where can we go to find one of those?
The American Physical Therapy Association, apta.org, does have a listing. Canadian Physiotherapy Association, pelvicglobal.com. That was a site started by a pelvic floor physical therapist out of Orlando. She does have a directory of many different professionals, not just pelvic physical therapists, but pelvic health professionals are listed there. So those are a few places you can go and see who's in your area. I could tell you who I think is the best person in your neighborhood, but it's an intimate therapy, and you ultimately are going to decide whether that is a good person for you or not. They all are regular physical therapists who have then taken additional training in the pelvic floor. There's certain levels, level 1, 2, 3, and most of them take all 3 levels. So they have similar training and education, but whether you connect with that person or not is going to be dependent on you going and meeting that person and going through a session with them. So I can direct you to those resources, and ultimately you kind of have to look at their bio, have a meeting with them, make sure when you call to book your appointment that person is licensed to do an internal evaluation and treatment. That's really what I think the gold standard of pelvic floor PT is. That being said, that only happens with your consent, and it may not happen in that first visit. It may not happen for 5, 6, 7, 8 visits until you are ready, and maybe you are never ready, but there's a lot that they can also help you with even without that internal evaluation.
I love that. Thank you. I really appreciate that. Now, we're getting close to wrapping this up, but I do have one question that I was really curious to ask you. What is one thing that most women think is normal about the vagina or pelvic floor that is not that normal?
The one thing that, I could say the leaking, that's pretty commonly people associate as being normal, but I want to see if there's something else different in there that I can see. Well, we touched on it a little bit, but I'll say this. It's not normal to have to push your pee out. It's also not normal to drip a little bit of pee after you've finished. So if you feel like you need to push, we want to figure out, is it because we have an organ prolapse? Is it because we have non-relaxing pelvic floor muscles? Is it because we're in a tucked posture position while we're trying to pee and it's not favorable to allowing the pelvic floor to relax? So we want to figure that out. And also, if we stand up, if we pee and we stand up and we notice there's a little bit of urine that dribbles out afterwards, that could also be a sign of organ prolapse or tight muscles as well. So those are two things that I think a lot of people face and don't necessarily know that it could be a sign of something that's maybe not working as optimally as it could.
Thank you. That's really helpful. All right, Kim, as we wrap up this podcast, I ask all my guests the same closing question, which is, what haven't I asked you that you'd like my listeners to know?
Well, we talked about estrogen, and a very common belief is that estrogen is dangerous, that estrogen causes breast cancer, that if you have a history of breast cancer, you can't use vaginal estrogen. So I would say a question could be, can everybody use vaginal estrogen? And my answer to that would be pretty much every single person can use vaginal estrogen. Even people who have a family history, who have had breast cancer or other types of cancer, even people undergoing active breast cancer. Now, I am not a doctor. I am not an oncologist. I surround myself with people who are very well informed. Dr. Rachel Rubin, Dr. Kelly Casperson, Dr. Corrine Men would be the people I would direct you to confirm the statement that I just made. Estrogen, to me, I consider it like an essential nutrient. And from the start of our menopause for the rest of our life, I think it is one very, very important tool to keep our vulvovaginal health, to keep our pelvic health working optimally, to potentially save our lives in the prevention of recurrent UTIs and UTIs going, people developing sepsis from UTIs.
I love that so much. I'm such a big proponent of bioidentical hormone replacement therapy. I talk about hormones maybe every 3 to 5 episodes. It's really a strong theme in this show so that people know. And I couldn't agree more with you. And also, I was going to say, you don't look like you're in your 50s. You look amazing. Is it the estrogen?
It's the estrogen.
I guess, sorry, one thing before I let you go. We didn't talk about UTIs and what we can potentially do for them since you brought them up. So do you have any recommendations?
Mm-hmm. Yeah. So gold standard would be, especially if you're post-menopause or postpartum, is vaginal estrogen. Also vaginal DHEA. Intrarosa is one name. Julva cream is another form of vaginal DHEA. Studies have also shown reduction in UTI risk with those, with DHEA as well. Drinking lots of water. Not using, the fragrance underwear or pads or products that are going to disrupt our vaginal microbiome. Part of the role of estrogen is maintaining the pH of the vagina, which is acidic. We should have an acidic vagina. And anything that is going to disrupt that is going to interfere with the microbiome, could potentially put us at risk. Also, part of there's the change in the pH, the thinning, the drying of the tissues can increase our risk, but also externally, the tissues can also thin and dry, and that can leave the tip of the urethra more exposed, which also is what can contribute to an increased risk of UTIs. So making sure we are flushing with water. We don't have to wash our vaginas. You soap, a gentle soap maybe, and water externally in our vulvas is fine. We don't need any fancy perfumes or douches or anything else to disrupt everything down there. Keeping estrogen so that we have good, supple, moist, juicy tissues that aren't going to be tearing. Vaginal DHEA potentially as well. Pelvic floor muscle training, that also helps with that blood flow and circulation. And making sure you are tested, because sometimes like a bladder prolapse or tight muscles can also present as a UTI. We could have similar symptoms of that urgency, burning, frequency of urination. So we want to make sure that we decipher that, is it actually a UTI or is it something else?
Good advice. Thank you. Please tell my listeners where they can go to find out more about you.
Vaginacoach.com is my website, and all of my social media channels, YouTube, Facebook, Instagram is usually where I hang out most. TikTok a little bit, is at Vagina Coach. And buffmuff.com, so that's BUFFMUFF.com, is where you can go and find out a little bit more.
It's been such a joy speaking with you. Kim, thank you so much for your time today.
Thanks so much for having me.
This podcast is a labor of love, and I'm dedicated to providing free content for years to come. If an episode has brought you joy, clarity, or valuable insights, your support means so much to me. A quick shout out on Instagram or sharing this podcast with a friend can make a big difference. If you're listening on Spotify or Apple Podcasts, a great way to help support the show, or even on YouTube, is by leaving a review. You can also help support my work by using any of the affiliate links that I leave in my detailed show notes, or visit my website, ashleydaily.com. I'm most active on Instagram if you're looking for me, so you can find me at Ashley_Daily. This podcast is presented for educational and exploratory purposes only. Published content is not intended to be used for diagnosing or treating any illnesses, disease, or disorders. Those responsible for this show disclaim any responsibility for any possible adverse effects from the use of this information presented by myself or my guests. Please consult with your healthcare provider before using any products or services referenced in this podcast. This podcast may contain paid endorsements for products or services. Any third-party materials or content of any third-party site referenced on this show do not necessarily reflect the opinions or standards of the policy of my guests. This podcast and my website, ashleydaily.com, represent the opinions of myself. The content discussed on the show should not and does not replace medical advice. The content here is for informational purposes only. Episodes on Welcome to Wellness may at times cover sensitive topics, including but not limited to depression, suicide, COVID-19, vaccines, events related to the pandemic, 5G, big pharma, nootropics, circumcision, psychedelics, hormones, the Women's Health Initiative, the use of plants medicine, abortion, geoengineering, terrorism, gender, AI, and sex, drugs, and rock and roll. You are advised to refrain from listening to this podcast if you are likely to be offended or adversely impacted by any of these topics. However, if these topics interest you, you just may have found your tribe. The information or opinions expressed on the Welcome to Wellness show are solely the views of the individuals involved and by no means represent absolute facts, opinions, or expressed by the host, and guests can change at any time. The views of my guests are solely their views, and the Welcome to Wellness show does not accept responsibility for them, and any action you take on the information contained within the show is strictly at your own risk. The Welcome to Wellness host, Ashley Daily, will not be liable for any losses or damages in connections with the use of this podcast. You should take all necessary steps to ascertain the information you receive from this podcast is correct and has been verified. None of the guests or the contributors on the Welcome to Wellness podcast will be responsible for your use of the information contained therewithin. Under no circumstances will the Welcome to Wellness show or my affiliate partners, suppliers, licenses, or guests appearing on the show be liable for any direct or indirect consequential damages arising from your inability to access this podcast. All intellectual property rights belong to me, Ashley Daily, and are included but not limited to the copyright and any other rights in the design. You are permitted to the Welcome to Wellness podcast for personal use, but not for commercial use without license. You may not make recordings of or otherwise copy this podcast. If you breach these terms, you lose the right to access the Welcome to Wellness podcast, and you must destroy or return any copies of the recordings you've made. Guests on the Welcome to Wellness podcast may at times provide information on or read extracts from third-party copyrighted work. The Welcome to Wellness podcast does not provide any medical or professional advice within these episodes. If you take any action or inaction as a result from the content you consume from within the Welcome to Wellness podcast, this is based solely on your decision, and the Welcome to Wellness podcast and Ashley Daily and my guests cannot be held responsible or liable for any of the consequences on such action or inaction. Thank you.